All right, let's dive into a really important topic in modern pediatrics, using antipsychotic medications in children. If you're heading into a peds or psych rotation, trust me, this is something you absolutely need to know.
So why all the focus on this? Well, look at this number. Up to 20% of kids and teenagers in the US have a diagnosable mental illness. That's 1 in 5. This is not some rare niche topic. It's a huge public health issue, and you are definitely going to see patients who need this kind of care.
So here's our game plan. We'll start with the big picture, then we'll meet a patient, Alex, and use his case to really think like a clinician. We'll go over the antipsychotic toolkit, talk about the crucial topic of side effects, and then wrap it all up with a high-yield review to make sure it sticks.
You know, the best way to learn medicine is by seeing patients. So let's get started and meet our patient for this explainer, Alex.
Okay, so Alex is 14 and his family brings him in. They tell you that for the last 6 months, he's just pulled away from friends, his grades are tanking, and he's admitted something pretty concerning. He's hearing voices when nobody's there. His family's also noticed that when he talks, his speech can be jumbled and really hard to follow. And super important, we've already ruled out substance use.
So, Alex is in front of us, we've got a story. Now it's time to put on our clinical hats and start connecting the dots. What is actually going on inside Alex's brain to cause all this?
Just take a second and think about it. You've got auditory hallucinations, disorganized speech, social withdrawal, all in a teenager. What's the first neurochemical pathway that should be jumping into your mind?
And this is the classic model, right? These positive symptoms, the ones that add something like hearing voices, are super strongly linked to too much dopamine activity in a specific part of the brain called the mesolimbic pathway. This whole picture is pointing right at early-onset schizophrenia. Now remember, this mesolimbic pathway is just one of several key dopamine highways in the brain. We'll see why the others matter so much when we get to side effects.
Okay, so we have a working diagnosis. Now we need to think about how we can help. Let's open up our pharmacological toolkit and see what options we have for a patient like Alex. So antipsychotics are basically broken down into 2 main groups. You've got the first-generation agents, the originals like haloperidol. They're really powerful blockers of the dopamine D2 receptor. They work, but they come with a high risk of some pretty serious movement side effects. Then you have the second-generation agents, the newcomers. Their mechanism is a bit more complex. They block both D2 and serotonin receptors. And here's the trade-off. You get a lower risk of those movement problems, but a higher risk of metabolic issues, like weight gain.
So what are we actually using these for in kids and teens? Well, the FDA has given the green light for several conditions. For a case like Alex's, early-onset schizophrenia in someone 13 or older, the second-generation agents are considered first-line. They're also used for things like bipolar disorder, Tourette's syndrome, and for managing severe irritability in kids with autism.
Choosing the right drug is just the first step. The real art and science of medicine comes in managing its effects. I can't stress this enough. Understanding, anticipating, and monitoring for side effects is absolutely non-negotiable, especially when you're treating a child or adolescent whose body is still developing.
This chart really shows you that trade-off we were just talking about. With the second-generation antipsychotics, we've successfully lowered the risk of those really troubling movement problems, the extrapyramidal symptoms, or EPS. But it's not a free lunch. We've taken on a whole new challenge: metabolic side effects. Weight gain is a huge deal, especially with drugs like olanzapine, and that can snowball into bigger problems like insulin resistance.
Let's try a quick case to see this in action. A 16-year-old girl, who you started on Risperidone a few months back, comes in because she stopped having her period. What's going on? How does the drug cause that specific symptom?
So here's how it works. Remember those dopamine highways? This symptom comes from blocking D2 receptors on a different highway, the tuberoinfundibular pathway. See, in this pathway, dopamine normally acts like a brake on prolactin release. When you use a drug like risperidone to block that dopamine, you're essentially taking the foot off the brake. Prolactin levels shoot up, you get hyperprolactinemia, and that can cause missed periods.
Now, even though the newer drugs have a lower risk of EPS, you still have to know about it. These are movement disorders that happen when you block dopamine D2 receptors in yet another critical highway, the nigrostriatal pathway. This is the exact same pathway that's involved in Parkinson's disease, which should tell you how important it is.
And EPS isn't just one thing. It's a spectrum, and it often shows up in a pretty predictable sequence. First, you might see acute dystonia. These are painful, scary muscle spasms that can happen within hours or days. Then you might see akathisia, which is this awful inner restlessness, along with Parkinson-like symptoms. But the one we really worry about long-term is tardive dyskinesia, these involuntary movements that can sometimes be permanent.
And then there's the big one, neuroleptic malignant syndrome, or NMS. It is rare, thank goodness, but it can be fatal, so you can never, ever forget it. The mnemonic to remember is fever. F for fever, E for encephalopathy, V for vitals instability, E for elevated enzymes, and R for rigidity, a classic lead pipe rigidity. This is a true medical emergency.
So given all these serious risks, monitoring is mandatory. It's not a suggestion. Before you even start one of these meds and at regular intervals after, you need a clear plan. We're going to track weight and BMI like a hawk. We get baseline fasting glucose and lipids, and then we check them again. And of course, baseline labs and an ECG if the patient has any cardiac risk factors.
Okay, we have covered a ton of ground here, from brain pathways to pharmacology to side effects. Let's switch gears and do a high-yield review. We're going to boil this all down to the absolute must-know facts for your exams and for the wards. So here are the takeaways. 1. Second-gen agents are first line for schizophrenia, but you have to watch for metabolic problems. 2. First-gen agents have a much higher risk of movement disorders. 3. The choice of drug is always individualized. 4. Monitoring is not optional. And finally, number 5, every single time you write this prescription, you are performing a delicate balancing act between helping your patient feel better and managing real risks.
All right, time for a quick quiz. A patient on haloperidol, a first-gen drug, suddenly gets a painful twisting spasm in their neck. What is that called? That's an acute dystonic reaction.
And for question 2, of all the second-generation antipsychotics, which one is the biggest offender when it comes to weight gain and metabolic problems? The one we're looking for there is olanzapine.
And let's end with this final thought. Knowing all the pathways and the side effects, that's the science. But being able to communicate all of this, to sit down with a child and their family and make a decision together, that's the art of medicine. So think about that. How are you going to have that conversation? Because that is what separates a good doctor from a truly great one. Thanks for joining me for this explainer.